Hello everyone, good evening. I hope you can hear me, please just let me know. I would like to welcome you to our live event. Again, my name is Caroline and I'll be your host. And today we will have a presentation on actual tactics for patients with recurrent implantation failure. Our special guest is Dr. Diana Obedniak from Ava-Peter Clinic, which is located in St Petersburg, Russia. Let me introduce you to some details on how it is going to work. So we will begin with Dr. Diana's presentation that will take approximately 20 to 25 minutes, and our Q&A session will follow after that. The whole webinar is being recorded, so you will be able to watch it again tomorrow, and it will be published on our site. So you will be able to take a look at it tomorrow. And remember that you can type in all of your questions in the chat section, and then the questions will be answered by Dr. Diana, and the questions will be published one by one as well. I hope all is clear for you, and I guess we can begin with our presentation. Dr. Diana, are you ready?
Yeah, I'm ready.
Perfect.
Hello, everybody. Good evening. First of all, I'd like to express my gratitude for your interest. So today we will touch very interesting topic, very important topic called implantation, the intensive development of embryology and advanced technology of reproductive medicine. The problem of recurrent implantation failure remains a challenging dilemma for fertility specialists. So today we will talk about problems. Historically, implantation understanding of implantation was as the process of delicate interaction between the embryo and the endometrium. But several years ago, fertility specialists and basic researchers obtained new findings proven that cumulus cells, microenvironment, and various growth factors play an important role contributing or hindering successful nidation. So who is to blame when we talk about recurrent implantation failure? No doubt we should assess the quality of embryo, status of endometrium, and take into account concomitant pathology. So as to concomitant pathology, there are few diseases which are proven to play crucial role in recurrent implantation failure. According to evidence-based medicine, hereditary thrombophilia is very significant, but only two mutations are important. But good news is that we have very effective treatment plans and algorithms to fix it. So we just have to know beforehand about these diseases. So we have to pay much attention to it and make screening before IVF cycle. But during our treatment, we can control it and fix it effectively. Another point is immunological factors. In Ava-Peter Clinic, we work with toughest cases, so we have very intensive and successful experience with rather rare situations. For example, antiphospholipid syndrome, unverified celiac disease, and different problems with thyroid. But in
Hello,
this case,
excuse me,
yeah,
Dr. Diana. Could you please speak up a little? We have some issues. We cannot hear very well. Could you speak up just a little?
okay, can you hear me
Yes.
right? Okay,
Yes, it is better. So please try to speak louder if possible so we can hear you
for
properly,
sure.
okay? Perfect.
Yeah,
Thank you.
talking about immunological factors, in our Peter Clinic, we work with toughest cases, so we're proud that we have very intensive and successful experience working with rather rare diseases, for example, antiphospholipid syndrome, unverified celiac disease, and some defects with thyroid. But in these situations, we always insist on individual treatment plan, which taken into account all the personal features, because we should be sure that we have taken into account the severity of the defect, all the multiple situations in the somatic diseases. No doubt, the quality of embryo can hardly be overestimated in IVF program. So I'm showing you this slide demonstrating the prevalence of abnormal embryos and the importance of routine morphological evaluation of embryo. If you already had underwent any IVF cycle, you have seen our science in embryo protocols. So you have seen meanings 4AA or 3AA, which describes the quality of your embryo. This slide demonstrates that even when we have so-called excellent quality of embryo, we should expect that the prevalence of a normal embryo will not exceed 56%, which is not very high percent. As you can see, so euploid is normal embryo. Single or double aneuploid means that there is a defect of one or two chromosomes, and complex aneuploid it means that there is a defect of several chromosomes. So it means that even in examination programs, sometimes there is need for pre-implantation genetic testing which examines all the chromosomes to be sure that the embryo is proven to be transferred in utero. The risk for such situations, there are cases with severe defects of sperm. So sometimes, even when the quality of egg is excellent, and when we talk about examination programs, the egg quality should be excellent. Sometimes we still have to perform pre-implantation genetic testing. Also, there are several methods of embryo selection, for example, time-lapse, ectopic, big data, selective transfer, but you should understand that it's just a negative selection of embryos. So we just try to avoid transfer of abnormal embryo. Unfortunately, up to date, we cannot fix the genetics. But what is the role of endometrium in implantation? In conditions in vitro in experiment, we have already obtained embryo development up to day 14 without any connection with the endometrium. In natural life, we also observe ectopic pregnancy. It's the cases when the pregnancy initiated but is located not in utero, so in any location of the uterus. In most cases, is uterine tube. In this situation, there is need for surgery, for urgent surgery, but we also understand that despite no connection with the endometrium, we have obtained pregnancy. So this is the basis for asking the question if the endometrium is so important. And nowadays, we understand the endometrium plays crucial role is a microenvironment which contributes or hinders the implantation. Several years ago, a very interesting experiment was performed. So you can see that here we're just comparing the endometrium of persons with normal fertility and in patients with recurrent pregnancy loss. So this is a situation when women have pregnancy, but unfortunately she has multiple miscarriages. The basis for this situation is abnormal compromised endometrium. So in women with normal fertility, when we transfer high quality embryo, we observe very specific transformation of endometrium, which helps embryo to be implanted. And when the embryo is low quality, when it's abnormal genetically, we see that there is no transformation of endometrium. So it's just a natural defense to avoid implantation of abnormal endometrium because in this situation pregnancy will interrupt. But in patients with recurrent pregnancy loss, it proceeded in any situation. So this is the basis for multiple interruption of pregnancy. Thus, endometrium is a biosensor of embryo quality and it's characterized by ability to accept embryo, so-called receptivity, and ability to select embryo and to avoid implantation of genetically abnormal embryo, so-called selectivity. But when endometrium is compromised, this fragile balance is also affected. And the causes for this alteration are morphological and functional effects. Talking about morphological alterations of endometrium, we usually mean intrauterine synetia, hyperplastic processes, precisely endometrial polyps, and inflammatory process, so-called chronic endometritis. As to hyperplastic processes and intrauterine synetia, this is a situation which requires surgical treatment, but the cause of this process is usually in process which results in formation of intrauterine synetia or hyperplastic process. So chronic endometritis is a condition involving the breakdown of the peaceful distance between microorganisms and the host immune system in the endometrium, resulting in a special type of chronic inflammation in the endometrium characterized by non-apparent clinical signs. It means that unfortunately you you will never uh, have any sign of clinical demonstration of this chronic endometritis except infertility or changing your menstrual bleeding. I'm sorry. Is the law? Can you hear me?
Yes, we can hear you. However, a little bit too quiet. So if you could try and speak up, that would be great. Okay,
Okay. Is
perfect.
it better?
Just a
Okay.
little bit, perhaps. I'm not sure if you can, but
Um, is it better?
yes, yes. Now it's a little bit better. Patients, please try to speak up, and should be all okay. All
Okay.
right. Good. Thank you.
Okay. So, uh, the prevalence of chronic endometritis differs a lot when depending on the group of patients talking about. So, in general population, the prevalence of chronic endometritis will not exceed 10%, but in patients with unexplained infertility, it will be about 28%. In patients with recurrent implantation failure, it will be about 45%. And in patients with recurrent implantation failure and good quality of transferred embryos, it will be close to 60%. It's very important because when we talk about egg donation programs, we always mean good quality of transferred embryos. Unfortunately, sometimes we have requirements of patients who had dramatic history of several attempts or ineffective attempts of IVF with good quality of transferred embryos. So In our clinic, we have a very intensive experience working with chronic endometritis. We even have patent for invention the effective model of treatment for that, which was approved by American Society for Reproductive Medicine. So we usually provide a diagnostic tool to assess the severity of this chronic endometritis, and after that, we we administer individualized treatment plan, which can include antibiotics, some regenerative medicine. We will talk about it a little bit later, which plays a good results in our treatment. But also there are time and place for functional alteration. Sometimes we see compromised window of implantation. So what is the window of implantation? Is the synchronization of the processes of embryo development and the maximum of endometrial receptivity. So in natural life, we usually have an egg after ovulation, which is fertilized, and and there is need for 5 or 6 days for for reaching her uterus or the womb of the woman. This time is also necessary for making endometrium mature. So this is precisely the very synchronization we're talking about. But sometimes this synchronization is altered and the window of implantation is a little bit delayed. In this situation, we see so-called good endometrium according to ultrasound examination, good embryo, but unfortunately, uh, uh, we have no pregnancy in IVF cycle. So there is, in this situation, we should examine this window of implantation, and after that, we can identify the perfect time for embryo transfer. And you can see the result that ordinary embryo transfer usually results in about 60% of clinical pregnancy rate. And if we have personalized embryo transfer after examination, the window of implantation, the successful rate will be about 85%, which is very good in our program. But also, no doubt, we have some effective tools to improve the efficiency of assisted reproductive technology. Several empiric therapy were suggested to improve our results, precisely so-called stretching, human immunoglobulin, plasmapheresis, vasodilators, even acupuncture. But unfortunately, according to evidence-based medicine, all these methods were not approved, but we still have uh, another method. For example, talking about recurrent implantation failure, I cannot not mention granulocyte colony stimulating growth factor. Several years in 2016, a meta-analysis was published to prove that intrauterine perfusion of granulocyte colony stimulation growth factor significantly increased the implantation rate and clinical pregnancy rate compared with placebo. Also, our investigation group had published an interesting trial comparing the effectiveness of method of administration of granulocyte colony stimulating growth factor. So besides intrauterine perfusion, we can administer it subcutaneously as injection. And in this type of administration, the successful rate will be much higher. But also, today is the era of regenerative medicine, when the use of one's own resources when drugs are powerless. We have very nice and very intensive experience working with the strategy of using autologous plasma to improve and accelerate the regenerative process. So your own plasma has several growth factors, which provides your natural defense, the function of your immune system. So this is the basis for using autologous platelet-rich plasma therapy. We performed randomized controlled trial evaluating the efficacy of this method for patients with recurrent implantation failure. We received patent for invention. This trial was awarded with American Society for Reproductive Medicine and Exomed Society. So we have two awards for this trial. As you can see, the pregnancy rate and implantation rate in study group with recurrent implantation failure, the pregnancy rate is significantly higher than in control group where we didn't have any intervention. Also, maybe you know that the thickness of endometrium is very important, and I bet your physician always told you that endometrium or mentioned you the thickness of your endometrium during your menstrual cycle. So we know that the thickness of endometrium day of embryo transfer is crucial point. So before this procedure, the thickness of endometrium didn't differ in study and control group. But after the procedure, in group when we performed this platelet-rich plasma therapy, the endometrium was significantly higher than in control group. That's why we recommend to perform this procedure only in patients with recurrent implantation failure, but also in patients with resistant thin endometrium. I also want to share with you two interesting case reports. So case report number one, 39 years old woman with one abortion with right-sided ectomy for ectopic pregnancy. When she came to us, she already had 8 embryo transfers. 6 of them were performed after pre-implantation genetic testing. After the second one, hysteroscopy and endometrial biopsy. But according to histological conclusion, there were signs of chronic endometritis, but no conservative treatment wasn't conducted. So when she came to us, we performed again hysteroscopy. You see that we observed polyp, which required surgical treatment. After that, according to her conclusion of histological examination, we made her individualized treatment plan, included antibiotics and platelet-rich plasma. And in the next slide, she had just continuous pregnancy, which resulted healthy boy. Case report number two, also 39 years old. He had already 11 embryo transfers. 6 of them were stimulation cycles and 5 of them as frozen thought embryo transfer. He had severe form of endometriosis, also severe chronic endometritis with autoimmune component. We also observed presence of anti-endometrial antibodies in peripheral blood. So applied tactics was to make moderate stimulation in the program of embryo banking with following pre-implantation genetic testing. Then we performed delayed frozen thought embryo transfer in natural cycle with platelet-rich plasma. We usually recommend natural cycle and embryo transfer in natural cycle because in this situation we provide um, very delicate intervention to the organism of woman, and under these circumstances we expect no problem during the pregnancy and labor process. So as a result, we also had clinical pregnancy and delivery via cesarean section because of some problems according to the somatic schedule. So take home message. In my point of view, implantation is a symphony orchestra. Endometrium is an active participant, not a passive partner. Thus, it requires careful attention in case of implantation failure. The current data only slightly opens metaphoric curtain in the universe of causes of repeated failures of implantation. And today, unfortunately, we have this limited arsenal of therapeutic methods. Thank you for your attention. This is a picture of a girl from the case report number 2. Thank you. I'm sorry for the sound, and thank you for being with us.
So Diana, for your presentation and providing us with some details and giving us some insight on the topic as well. We will be able to move on now to our Q&A session. So I believe you have lots of questions. So remember, you can type them all in our chat section, and we will be able to answer them. I just would like to remind you that if you have any troubles with hearing us, this is being recorded, so you will have a chance to rewatch the webinar. We apologize for any inconvenience. Sometimes we just cannot change that, I guess, at this point, but we definitely want to let you know that if you would like, you can definitely rewatch it tomorrow as well. Okay. It will be published tomorrow during the daytime. I cannot give you the time exactly, but if you'd like, you can send an email to us, patient@eggdonationfriends.com, and I can I can let you know as soon as it is online. All right, I think we have a question now, so let me look. Okay, Dr. Diana, are you ready? We have a first question.
Yeah.
What diagnostic test in what priority order would you recommend with recurrent implantation failure?
Thank you for your question. Well, usually the priority order is uh, is to be identified according to your individual features. So I just can tell you the diagnostic tests we should be performed in any cases. So in any cases, we should assess endometrium. This requires to perform hysteroscopy. So this is the surgical surgical diagnostic test, but it's very delicate. So it lasts about 3 or 4 minutes, but it's the so-called golden standard for assessment of endometrium. In this case, we can assess it not only by our eyes and by our video equipment, but also with the following histological examination, which can give us information about severity problems of endometrium if there are. Also, we should assess if there are any defects with blood, for example, hereditary thrombophilia. If we talk about patients over 35 years old, we also should take into account the possible problems with embryos. So sometimes we recommend implantation genetic testing of the embryos, and after that we insist always in selective embryo transfer. So we usually transfer only one embryo, but which is proven by pre-implantation genetic testing.
Okay, thank you for answering that. And let me have a look. We have another question ready from Amanda. I wasn't advised to do PGS with donor egg. Do many women do these tests?
Well, um, in ordinary egg donation programs, we do not recommend to perform pre-implantation genetic testing, except the cases when there are severe problems with sperm, because it's a high risk for formation of abnormal embryos. We performed lots of implantation genetic testing in egg donation programs when patients insisted on additional testing or when there was need to transfer selecting the gender of the embryo, for example, boy or girl. So we see that in most cases, because we pay much attention for selection of egg donors. So we make previously a great and very wide and very intensive examination of donors, even genetic basis, not only karyotype but also opportunity to have career of some genetic diseases. So not many clinics perform such intensive examination of egg donors. But even in such cases, after such examination, we receive some embryos which are abnormal. But all these cases were associated with severe sperm defects. So if unfortunately your couple has some severe problems with sperm, so you see the lower number of normal spermatozoa or the volume of ejaculate is very low, it's better to perform pre-implantation genetic testing even in egg donation programs. Okay, next question.
Okay, thank you. Thank you for the question, Amanda, and for answering this one as well. Diana, let me have a look. We have another question. I've had fibroid this impact on the lining. How long would I need to wait if I had it removed? Would I wait before I start the treatment?
Well, it depends of the sizes of fibroid because if and location of fibroid because if the fibroid is located mostly in the uterus of in the cavity of the uterus, uh, we will recommend you to perform hysteroscopy and to make surgery of this fibroid in during this surgery. In this case, you will need to wait just about 6 months. But if there will be a need to make a greater surgery, so-called laparoscopy, usually there is need to wait, for example, 1 year to be sure that uterus is ready for childbearing, for childbearing. That is the crucial point. So if you are going to use your egg or combination of your egg donation, it's better to perform um, in vitro ovarian stimulation and IVF cycle before this surgery. After complete recovery to then implant. But the prognosis is always beneficial after this situation. So if the size of the fibroid is more than 4 sizes or 4 centimeters, according to European and American guidelines, we have to recommend the surgery. But the prognosis for this patient is very good.
Okay, thank you. Please, if you could speak up a little bit, okay? We have
Okay.
trouble hearing you very well. Okay, thank you. And let's have a look. We have another question. I have autoimmune conditions like arthritis, the high NK cells, had 6 cycles with no implantation. I had the ERA done. What do you recommend as part of IVF treatment with someone with underlying autoimmune conditions?
Uh, well, usually it's a very good question. But unfortunately, when we talk about patients with arthritis and uh, high prevalence of NK cells, we usually observe very poor quality of embryos. So, if you talk about embryos which were obtained with your egg, no doubt you should perform pre-implantation genetic testing because unfortunately in most cases the treatment of arthritis and some autoimmune conditions will affect and do a lot of harm to the quality of the egg. So uh, usually in this situation, the basis for recurrent implantation failure will be the quality of embryo. If we talk about egg donation programs, we usually have to assess again endometrium, but not for the point of chlamydia or polyps, but usually there are also autoimmune disease of endometrium. So in this case, we should to provide regenerative medicine, and this is the only situation when they recommend infusion of immunoglobulin intravenous, the human immunoglobulin, which provides the proper function of your immune structure, because this is not only the key point for recurrent implantation failure, but also it plays a crucial role in formation of miscarriage. So unfortunately, in this situation, there is a risk for miscarriage. That's why we should be ready and provide prophylaxis for this severe situation.
Okay, perfect. Thank you for answering this question as well. And we have another question. I am 44. What are my chances of getting pregnant with donor eggs?
Well, with donor egg, the chance of getting pregnant is very high. Just in ordinary program without implantation genetic testing, but with use of donor egg, we have about 70%. So just if there is no problems with sperm or the defect of sperm is just not very severe, we don't recommend pre-implantation genetic testing, but successful rate is about 70%. So the prognosis is beneficial.
All right.
One point
Thank you.
attention just that in this age we usually recommend a proper hormonal support because usually in women of this age we observe some problems with hormonal features, so we should provide the proper defense of miscarriage. So we just prolong hormonal treatment to be sure that pregnancy will progress. This is one point. Thank you. Another question.
Yes, of course. Thank you. I've had 6 embryos transferred from 3 different donors. Would aspirin or and prednisone be a good low-cost option for my next cycle?
Well, talking about good low cost option, maybe yes, but I strongly recommend you to perform extended diagnostic before performing next transfer of embryos because 6 embryos transferred from 3 different donors, it's a certain basis for understanding that the problem is not in the quality of embryos. So we should pay much attention to your endometrium and to excluding the problem in concomitant diseases. So I'm strongly recommend you not to perform embryo transfer before additional examination of yourself because I'm afraid just prednisolone or aspirin will will not affect in good result because in some cases it's very effective, but uh, it's effective when there is point for administration. So usually there are some problems with blood. For example, there is antiphospholipid syndrome. In this situation, we can administer not only aspirin and prednisone, but also some injections like sun and so on. But no doubt there is you need to perform more extended diagnostics. If you don't mind, just send me your embryo protocols. I'd like to um, look through it to be sure that the quality of donors were good enough, that the embryos were good enough, because maybe there is also a problem with sperm. And in this point, we would try to, but telling frankly, I think that there is a point for additional examination of your endometrium and excluding concomitant diseases, because 6 embryo is a very much number of embryos you were transferred. I think that some problems were not estimated.
Okay, perfect. Thank you for this. And let's have a look at another question. It's similar to the previous one. However, let's have a look. I am 48. What is the success rate for donor egg implantation?
Yes, the rate of success will be the same because the tactics will be the same. So it's about 70%. But before performing this egg donation program, we usually make examination of you to be sure that um, we we make embryo transfer to the uterus, to the endometrium, which is perfectly prepared for this embryo transfer and for pregnancy. This is a crucial point. So in this situation, the rate of success is about 70%.
Okay, perfect. Thank you. We have another question. Does adenomyosis also hinder implantation? I have underactive thyroid, so I am not sure if to try again after 3 failed IVFs.
Well, adenomyosis uh, always affects implantation, but there are also some stages of adenomyosis. So not many women have severe forms of adenomyosis, though endometriosis and adenomyosis is one of the most difficult diseases in gynecology and reproductive medicine. But today we have some very effective algorithm of preparations. So sometimes we recommend 2 or 3 injections when we stop your menstrual bleeding. In this situation, your uterus uh, becomes more compacted, so we just nivellate this adenomyosis effect. So this is a great basis for making implantation successful. Another point, usually uh, there is endometriosis associated chronic endometritis. So you should be sure that there is no point of uncompromised endometrium. I would like you to just pay attention to your menstrual bleeding, because in such situation you can see sometimes some brownish bleeding in the end of menstrual period. This is one of the very significant signs that there is a problem with endometrium. So if there is such, there is no doubt a need for hysteroscopy to be sure that there is no problem with endometrium, or to be hysteroscopy is not just a diagnostic tool. Is the first stage of treatment, because we can fix some problem surgically just performing this manipulation. So after that, we will also recommend you, according to the obtained data during hysteroscopy, individualized treatment plan, and after that, just to perform embryo transfer, which should result in pregnancy. And according to underactive period, uh, well, it depends, because underactive thyroid is just a point of functioning of your thyroid. It's not. the cause of this compromised functioning. We should understand if there is the problem with the morphological status of thyroid or there is some autoimmune disease of thyroid. In this case, the tactic will be a little bit different. But in any case, the prognosis is good. So please don't give up. Everything will be good. Just you need proper preparation.
Okay, perfect. Thank you for this as well. And let's have a look at another question. I have done IVF egg donation 4 times and didn't work, although I took aspirin injection for blood thinning, also progesterone injection.
Well, I understand that you are very disappointed after this dramatic experience, but unfortunately, I have not enough information about your anamnesis. Could you please provide more details, maybe what diagnostic tools were already applied to be sure that there is no problems with your blood test, with your endometrium? Because progesterone injections or just progesterone administration is not um, some, it's just a routine practice. It's just a need in egg donation program. So according to this information, I just have feeling that the support and the preparation of your endometrium was a routine. So please provide more information to for me to explain you what some points that you can pay attention more. Please give a little bit more information about your history.
Yes, exactly. Remember, you can also send all your questions to patient@eggdonationfriends.com and we will be able to forward your questions to the doctor as well, okay? And if you could provide us some more details so the doctor can answer your question better, okay? Thank you. And let's have a look at another one. Is there any 100% guarantee IVF egg donation?
Well, in any cases up to date, there are no 100% in one cycle, but in our clinic and in one clinic also in Europe, we provide so-called IVF with guarantee program. It means that we guarantee to help you with the pregnancy in free embryo transfer, and if there is no pregnancy after this embryo transfer, we guarantee you to make a refund of over 50% of the price of this program. So only clinics for which are very reliable and which are very persuaded in proven and which are proven with their efficacy can just afford itself. Because when we talk about egg donation programs, we talk about a very high percentage of successful rates. But as you see, if woman who will bring this pregnancy is unfortunately underestimated, we see unsuccessful results. So we have an algorithm of examination and preparation women. Sometimes it lasts about 2 weeks, sometimes it lasts about 3 months. It depends on personal features. So our goal is to make and to provide you a healthy child just in one embryo transfer. So we pay much attention, we pay great attention to preparation of endometrium, of uterus, of organism in general. Sometimes we pay much attention to emotional status of women, especially for women after recurrent implantation failure. That's why we're proud to announce a very high successful rate. So the answer for this question, in one embryo transfer, unfortunately, nobody can guarantee 100%. But in free embryo transfers, the statistics is that the cumulative pregnancy rate is about 98%. So it's very close to this point. Next question.
All right, thank you. And let's have a look at the next question. Can I do donor egg without using Prelome gel? My nurse told us today we need to use it with injections.
Well, uh, no doubt we will have to recommend you uh, support, hormonal support with any form of progesterone. Pregnant gel is considered to be one of the most convenient forms of progesterone, as it's just a vaginal form. But if you have any just uncomfortable feelings, we can recommend you progesterone, but in form of tablets or in form of injections. We usually not recommend injection because it's so-called not very friendly for patients. And when it's a very uncomfortable form of treatment, we usually observe a greater risk of patient's mistake. So we usually just recommend a form of a vegetal form of progesterone, for example, trinone gel or ultragesterone, or tablets. As in cases of severe progesterone insufficiency, we recommend injections with progesterone. So there are different forms of progesterone, but no doubt you will have to select one of them which is more convenient for you and which is more appropriate for your medical history.
Okay, perfect. Thank you for this as well. And let me have a look. We have another question. Ready? I have had one chemical pregnancy with donor embryo. I am thinking of trying donor egg again. I have just had my ERA test done. Are there any other tests I should go under?
Well, it was a very wise decision to perform error test. If it's okay, you can repeat this donor embryo transfer. But usually, when we talk about chemical pregnancy, biochemical pregnancy, we understand that the window of implantation is uncompromised because if the window of implantation is delayed, unfortunately, we will not observe any interaction between embryo and endometrium. So in this case, we will not observe any HCG, so any biochemical results, so no enhancement of HCG. So biochemical pregnancy means that the window of implantation is good. So you need to repeat this embryo transfer just in the same conditions, but you should pay much attention to greater progesterone support. Maybe this is a point to make it much stronger. For example, combination of vaginal forms of progesterone and tablets. Also pay attention to concomitant diseases. Maybe you'll need to take aspirin or injections of Lexan to be sure that your blood is good for childbearing. But in any cases, biochemical pregnancy is no doubt it's not our final goal, but this is first step to successful result because when we have biochemical pregnancy, we understand that many things were done properly. So, just for example, window of implantation, we get the proper role of implantation. So, please pay much attention to the status of endometrium. So, be sure that there are no micropolyps. Sometimes uh, general physicians just don't see them by ultrasound. but and try again. I'm sure that you will manage to offer your pregnancy. Okay, now question.
Okay, perfect. Thank you. Does embryo glue scratch interlipids help with implantation?
Well, no doubt in patients with recurrent implantation failure, we try to do our best, and sometimes we even apply, as I mentioned, that scratching, embryo glue, these interlipids, and immunoglobulin, human immunoglobulin are not properly proven according to evidence-based medicine, but unfortunately the experience of application of all these methods it's not rather uh, rather large all over the world. We all have some couples who succeeded with safety when we apply stretching or interlipid, but it always should be administered individually because, for example, and also we should pay much attention of the method of application. For example, stretching was suggested when we perform it in the middle luteal phase. So it's about the day 9 from 19 to 22 of your menstrual cycle, and this should be the previous cycle, just before the cycle when you will perform embryo transfer. So if you make this stretching in any other day of your menstrual cycle, or for example 2 or 3 cycles before embryo transfer, it will just not work. But this is not the point of this method, just not proper application of this method. Concerning interlipids, it's not a very simple medication, so you should be very accurate with it. Usually, we perform it when there are some autoimmune diseases or antiphospholipid syndrome. So, it's not recommended for any patient with recurrent implantation cases. So if you provide any details of your medical history, I can recommend you something more. I can recommend you some searching methods for you. But in all the situation, we're just trying to do our best to recommend, on the other hand, approved according to the evidence-based medicine, but sometimes just methods which should work precisely in this couple. So this is the basis for our good practice.
Okay, thank you. I had two ET donor eggs in both cycles. I had fluid in the womb, which cleared up before ET. I don't have polyps or cysts. Why would this happen?
Well, fluid in the womb is considered to be the sign of chronic endometritis, no doubt, according to Spanish guidelines, European guidelines, and Russian guidelines. We always have to examine more properly endometrium. We usually have to administer antibiotics to fix problem even when we don't have any sign of polyps. And usually we just cancel embryo transfer. If we have fluid in the womb, we usually do not perform embryo transfer till we have appropriate optimal condition of the endometrium and uterus. But if the quantity of this fluid is very big, we just have um, we're just worrying about flushing out of the embryo. If quality of fluid is not very large, we also are worried about that inflammatory process will do harm for embryo and wouldn't allow pregnancy to be initiated. So it's always a very bad prognosis. So We never perform embryo transfer when we absorb fluid in the womb by ultrasound.
Okay, perfect. Thank you for this as one as well. And let's move on to the next question. We have a case of premature ovarian failure and into our second cycle of IVF where in round 1 there was no symptoms to indicate otherwise. Now I have been recommended with menopause. Would you recommend that?
Well, we have very intensive experience working with POF, but I need to know your AMH level and your FSH and LH level, because even when we have lots of patients with AMH about 0.1, 0.2, and we have clinical pregnancies. And but we when we talk about the selection of medication, we always should assess not only AMH but also FSH and LH. Nowadays, all over the world, the combination of two medications called pergoveris and letrozole uh, is considered to be very effective for such patients. But also, I need to know your age, because the dosage and the combination, because we have up to date we have about 20 types of ovarian stimulation, so we can individualize the ovarian stimulation very properly. But I need more information.
Mhm.
So
Um,
generally, yeah,
I
uh,
think we have the information actually, as you can see, and the patient is 32.
32. 32 is
Yes.
very great prognosis. So uh, FSH is 17, AMH is less than zero point 0.1. So usually we will recommend you the combination of pergoveris about 300 and letrozole about 4 tablets a day. So, but no doubt we should assess your BMI, and your physician should make follicular genetic monitoring by ultrasound examination. So please don't take any medication without controlling by your physician. It's a very important thing. Never take any medication without controlling by the doctor. But in general, this not very this is um, not very this is rather tough situation, but the prognosis can be very good according to your age.
Okay, perfect. Thank you for this. And we have a few questions left. We will be slowly finishing, but let's finish the
Yes,
questions, okay? And from Michelle, it is winter here in the UK. I like to sit right next to the heater. Can this have a negative effect on donor transfer? And two, also find it hard to drink a lot of water. How much do you recommend to drink to aid implantation?
well, concerning the heater, please don't be worried about this. It's better to sit right next to the heater, but to be sure that you will not get ill and have flu this time. So please just uh, feel comfortable to sit near the heater, just to have a comfortable temperature around you. And concerning the volume of water, recommended volume of water, well, according to all the general recommendation, the recommended volume of taking water is about 1.5 liter per day. It's usually to be counted like 300 milliliters according to according to 10 kilograms of your weight, but not more than 2 liters. But please don't pay too much attention to this in context of successful rate of implantation, because as we understand in natural cycle, in natural life, women get pregnant without any with, without any information of taking water or not taking water. So it plays a significant role when we talk about uh, IVF cycle and controlled ovarian stimulation, but not in cycle of donor transfer. So just please don't make any changes in your life because it will make you distressed and this will play not very good role in implantation. So just try to calm down, to feel comfortable, and I'm sure it will result in good results of your IVF cycle.
Perfect. Thank you for this as well. And let's have a look. We have another question. Could too much estradiol doctor advise a gel and pills of the hormone at the same time be a reason of a failed implantation with a good embryo?
Well, usually we recommend estradiol when we have to prepare endometrium, and some physicians, some doctors prescribe a very great dosage of estradiol in case of thin endometrium. So this is the only reason to say that to tell you the truth. This is the only reason when physicians can prescribe too much estradiol. So I bet that not the dosage of estradiol played a crucial role in implantation failure, but I'm afraid that endometrium was underestimated because endometrium and bad growing of endometrium is always a sign of compromised endometrium. So endometrium will never be thin just with no reason. So no doubt you will have to perform hysteroscopy to investigate your endometrium. After that, I would recommend you to perform plasma-rich therapy with platelet-rich plasma therapy (PRP) because this is a good point to fix the problem with endometrium without using high dosage of estradiol or any other hormones because this is the basis of regenerative medicine. When your endometrium becomes better without hormonal medications. But please pay more attention to your endometrium and don't plan other embryo transfer without examination.
Perfect. Thank you for this question and the answer, of course. And I believe we have the last question for today. Also been prescribed levothyroxine, even though my thyroid levels are fine. Is this normal? Apparently, I am told it needs to be below 2.5.
Yeah, usually when we talk about non-pregnant status of women, um, the normal level of thyroid function is of TSH is 2.5. But when we talk about pregnancy and implantation, successful implantation, we usually intend to have TSH about 1.5. So in some cases, we prescribe very low doses of levothyroxine, about 25 milligrams per day. But we usually just not prescribing it with no reason, but we uh, control it just a few days after embryo transfer. Because when implantation proceeds, sometimes we see a very high release of TSH. So even when I just made a blood test for TSH before your embryo transfer, it was, for example, 2.5 or 3.1 is rather normal for non-pregnant patients. But after embryo transfer, it can elevated to 5 or 6. So this is the basis for additional control. So if you have TSH level about 2.5 and you have never observed it higher, I I think we will never recommend you levothyroxine, but we can recommend you to control it more properly. And usually we prescribe blood test for TSH just 2 or 3 days after embryo transfer because this is a dangerous period for elevation of TSH. And if we observe elevation of TSH, no doubt we prescribe levothyroxine.
All right. Thank you for this. I believe that was our last question. So thank you all for all of your questions and Dr. Diana for your time as well and providing us with the answers. Is there anything else you would like to add?
Thank you so much for your time. I'm very sorry for sound quality. I'm a little bit confused. We tried our best and we checked it beforehand. But if you have any question, please don't hesitate to contact us through the Egg Donation Friends. We will provide all our answers. And if you have any desire to have Skype consultation, we can make an arrangement for free just for participants of this meeting. Thank you for your time.
Diana, for this. So, of course, remember you can write to us to patient@eggdonationfriends.com. We will be happy to forward all your questions to the doctor. And if you wish to have a Skype consultation as well, it is possible. And I guess that will be all for today. Hope you can also join us for our last webinar this year that will take place in 2 weeks' time. And I hope you've enjoyed this and got some answers. Thank you again. Have a good night, everyone. Bye bye.